Dr. Sagar and resident. I'm presenting today role of lasers in pilonidal sinus disease. As we know, the name is derived from the Latin word that is pilus meaning hair and nidus meaning nest. Before we go into the plan of management and video presentation, I would like to give what is basic thing about the pilonidal sinus which we have to know before we go for a plan of management. One is navicular line. So what is navicular line is whenever the patient comes with a pilonidal sinus, we have to make him stand and make a line which is drawn by pressing both the gluteal muscles, and we have to draw the line, the joining point where it comes. These are the lines basically give you the idea about the sinus opening and secondary sinus openings which we seen in the pilonidal sinus disease. Based on this navicular line concept, the TASL in 2018 gave the classification for the pilonidal sinus disease. Based on that, there are types of pilonidal sinus, that is type 5. So if we see the patients which we get in the OPDs are mostly in the type 4 and type 5. That is one or more sinus pit out of the limit of navicular lesion, and type 5 is patient developing recurrence. So this classification was again updated and studied by a Turkish study which was published in 2020, that is in the colorectal disease. What they have found out that the midline openings which were there, we called this as a pit. There are communication with this opening having in the forming of fistula which will be seen in the anal region also. So based on that, they have more classified the pilonidal disease. In type 1, if we see type 1A and type B, that is limited at intergluteal sulcus with a single sinus orifice, and type B limited at intergluteal sulcus with more than one sinus orifice. Type 2 again divided in type 3 is again divided into A and B. If we see orifices of sinuses or fistula extend from intergluteal sulcus to lumbar region. Type B in 3 is orifices of sinus or fistula extend from intergluteal sulcus to perianal region. Type 5 and type 4 and 5 are more of a similar, but yes, recurrent pilonidal sinus is in type 5, and type 4 is complex pilonidal sinus. In that, orifices of sinuses or fistula extend from intergluteal sulcus to a lumbar region or perianal or gluteal region. This was the update made by the Turkish study, which was not by the TASL in his classification. So what we know about the pilonidal sinus surgery? There can be excision, and which is now recently what we are doing is no excision. If we see in the excision, we can do healing by a secondary intention, secondly by a primary closure or by the flaps. If we see healing by secondary intention, in that we are doing saucerization, VAC or marsupialization. In primary closure, if we see, we do a midline closure or off the midline closure. And flap, we know Limburg flap is there, Masicon flap is there, and Chirodakis. In no excision technique, which we are discussing today, is laser and refining Gibbs. What I am doing in my practice. Minimal invasive surgeries, we see there are options with the help of endoscope, which has been studied that showing 100% results in the endoscopic pilonidal sinus disease treatment. In that, if the patient is having abscess, yes, we can use the endoscope for the drainage of the abscess, and VALAP, yes, video assisted laser ablation of pilonidal sinus. How do we manage the patient? Refining Gibbs plus sinus laser therapy, what we are doing, what I will show you today. Secondly, yes, Bascom flap, we have the good results for this, and endoscope, as we discussed, 100%. There are results showing no recurrence in the endoscopic cases. So, case presentation, a 28-year male approached with a discharge from the gluteal cleft. On local examination, one healed opening on the left gluteal cleft, and midline there was an opening. Routine investigations were normal. The sinus was subcutaneous. MRI was done to confirm this. After giving the jackknife position, first thing what we are doing is refining Gibbs. If you see the photograph, we have to take the photographs of pilonidal sinus disease. As I have attended the conferences, in that what I have learned, I am showing you. See, why we take the photographs are because if we see the openings as per the navicular line, always we get the pits opening which is present in the midline, and secondary openings will be away from the midline. Why this is happening? Because if we see the hair in a hair movement, the hair movement is go in a one direction only, because if we they have the direction. Why the direction is this? because there are the serrations present in the hair. That's why we get the pits in the midline and secondary opening away from the midline. So trephining Gibbs is the again technique developed by Dr. Gibbs. It is nothing but we have the punch biopsy, that is skin biopsy punch. We use it, we remove the pits, and also if the secondary openings are there, we remove that opening also. After removing that openings, you get the second picture. If you see the picture you get with the hair follicles or the complete track of the sinus. So we go ahead with the video presentation now. After giving the jackknife position, widening the opening using the skin biopsy punch, and yes, curate the track and remove the hair follicles and debris with the help of either a scoop, or you can do the washing also, making an opening. Wash can be given with the H2O2 betadine. Also, if you see there is a abscess cavity away from the midline, you have to create a secondary opening there so that the wash can be given from that cavity also. So make a thorough wash with that secondary cavity opening, which I have seen in my patient also. Use the radial fiber for the ablation. The fiber 10 watt has to be used per mm per second. Post-operatively, the discharge is 3 to 4 weeks. We have observed there will be complete healing of the openings which were there. So the technique in this case, what I have used is trephining Gibbs, and secondly, you can use the laser fiber if you have. If you don't have the laser fiber, that is also okay. The study done by the trephining Gibbs has proven the results showing that the recurrence is very less, which will be showing in the next slides also, and can be prepared if fails, and again you can do this. But yes, it is a cost effective. What study says, 90% success rate in the first application, and yes, 78.3% in second applications of the lasers. So teaching points, if you see with this presentation, is one way of hair movement. We have to remember this navicular line. Always do the marking of the patient whenever patient comes to the OPD. In the standing position, you have to compress both the gluteal region and draw the line. Evaluate and choose the correct plan, and MRI is the choice of investigation in such cases. If you see the picture, what we are doing and now what we can do for the patient, and the results are, yes, the result, if you see, there are good results, and with the same the flap showing the results. The studies are yet showing that the laser and the newer technique of minimal invasive techniques are used in pilonidal sinus treatment. Thank you so much.
During your presentation, you said that you were 100% successful. There was no recurrence.
Yes, sir, there are results showing, but the number of participants in that case are very less. So still the studies are ongoing. The study done by the Kushal Mittal sir, he has shown that 95% there are success rate in his study.
Well, it's a very bold statement in a pilonidal sinus. When you're saying it's 100% success rate. Yeah. Another way, you just showed us the procedure in the video, yeah, where you are ablating the
yes,
residual area.
Yes.
If you just keep it open, it will heal by secondary intentions.
Yes.
What advantage does the laser have?
So laser advantage, having the laser is basically it helps to the ablating the track. Secondly, if there are missed out some openings, that also can be closed off with the help of the laser.
What is the position you give the patients while you perform surgery? Sir,
actually we are using the prone position, and also we are tagging the gyneplast to stretch both the gluteal side. So it is a jackknife position.
That's not
prone.
You said it was a jackknife position. That's why I'm asking.
Yeah.
Anyway.
Thank you, sir.